Hello everyone. Please let me know if I'm audible and visible and you're able to see the presentation. Okay, thank you. So today's short session, this is going to be a quick run through of MCQs, must know MCQs for the FMG exam. Right, so we will be going through questions based on the recent pattern. So see, most of the questions nowadays are a little bit clinical and a little bit they have images. So these questions are going to be like that, a little bit more on the clinical side. But before we go on to our questions, I would just like to share a little bit of information with you. Like those of you who are still not a part of our Plus platform, you can use my code, that is Dr Sudha, to enroll for our Plus subscription. And if you want the best of both Unacademy and Prep Ladder, then you can go for the Iconic subscription. And this is the Unacademy Unlock, and this is a special offer that's going on for you, and this is from the 17th till the 22nd of July. And now to tell you about the different batches which are now going on our platform. See, we have an INI CET batch which will start on the 21st of July. We have this Focus FMG 2022 batch which has started on the 11th of July, and this is going to be from July to December, where there is going to be a complete coverage of all the 19 subjects and interaction with some of the top educators in our country for medical education. And in case you miss the sessions, then the recorded sessions are also available. And we also have a very good question bank which has around 25,000 questions for you to practice. There is also this NEET PG 2023 test and discussion batch for those of you who are retaking the exam. And this is mainly based on test and discussion and high yield theory format. And this is for those of you who have gone through the syllabus once and who are retaking the exam. Right, so these are the different NEET PG subscriptions that are available. So let us start with the questions. The first one: a 14-year-old patient presents with a complaint of frequently changing glasses, and on retinoscopy the value in the right eye is -9 diopter sphere and -7 diopter cylinder cross 115 degrees, but the vision does not improve much with glasses. Now, what should be the next investigation? And see, this is the clinical picture that's been given to us. So what are the options? The options are perimetry, specular microscopy, corneal topography, and corneal scraping. So tell me, which is the option that you will choose? So the options are perimetry, specular microscopy, corneal topography, and corneal scraping. Correct. So you've told me corneal topography, right? So the answer to this question is corneal topography. So first of all, let us try to understand what is the diagnosis. See, they are talking about an adolescent, a 14-year-old, and what is his complaint? His complaint is frequently changing glasses. And see, let us look at his refraction. It is in minus, meaning it is myopic, right? But there is a myopic sphere and a myopic cylinder both. So this is a myopic astigmatism. But the problem is that despite wearing the glasses, the patient's vision is not improving much. And if you look at this image, see, what is this image? It shows that when the patient is asked to look down, this cornea is pressing on the lower lid. So what is this sign called? This is a very common image-based question. This is called as Munson's sign. So when the patient is asked to look down, the protruded cornea, it is pressing on the lower lid. Okay. So all this together, it gives us a diagnosis of keratoconus. It gives us a diagnosis of keratoconus. Right. So now what is the investigation here that will help us to confirm the diagnosis of keratoconus? It is corneal topography, which is an analysis of the corneal surface. So it will help us to analyze the corneal surface, and that is how we will be able to confirm the diagnosis of keratoconus. Okay, so this is the answer to this question. Now, once one of you has given me perimetry as the answer, please understand that perimetry is evaluation of visual fields. And where do we evaluate the visual field? We will evaluate the visual field for glaucoma or for some neurological conditions, like for example, optic chiasma, compression, etc. So perimetry is evaluation of visual field, which does not have a role in confirming the diagnosis of keratoconus. Okay? So for this question, the answer is corneal topography. Okay, let's go to the next question. Which of the following statements is true regarding the instrument that is shown in the picture? Which of the following statements is true regarding the instrument that's shown in the picture? So this is the instrument here, and the options given to us are the magnification is 5 times, a converging lens of 20 diopters is used for viewing, and this helps us to view up to the retinal periphery, and the image is virtual and erect. So which of the options is correct? Which of the options is correct? Okay, so some of you are saying the option 4 is correct. Right. The correct option is the image is virtual and erect. So first of all, let us look at what is the name of this instrument. The name of this instrument is the DO. This is the direct ophthalmoscope. So see, how do we identify it? There is a handle and there is a head, and here there is a dial at the side. Why do we use this dial? We are supposed to hold this instrument in the hand, go close to the patient, rotate that dial and focus the retina. Right? So this is your direct ophthalmoscope. Now let's look at the first option. Magnification is 5 times. This is wrong, because for the direct ophthalmoscope, the magnification is around 15 times. Magnification of DO is around 15 times. And because the magnification is high, that's why it does not allow you to view up to the retinal periphery. It will allow you to view only the central part of the retina, that is the disc and the macula. So these two are wrong. And converging lens of 20 diopters is used for viewing. This is also wrong, because a converging lens of 20 diopters is used with your indirect ophthalmoscope, not with the direct ophthalmoscope. So all these options are wrong. So what is right is this, that it produces, the optics of the instrument is such that it produces a virtual image, and therefore it is an erect image. Right? So let's go to the next question. So this is your indirect ophthalmoscope. See, this is the IO which we wear on the head, and with this you need a converging diopter of 20 diopter lens. This is your DO. Okay, let's go to the next question. A 60-year-old patient with history of heart disease presents with sudden loss of vision. And on examination, this is what is seen, which is the cherry red spot. Now, what is the treatment? So the options given to us are wait and watch, intravitreal steroids, ocular massage and immediate paracentesis, and intravitreal anti-VEGF. Right? So tell me, which is the option we should choose? Which is the option that we should choose? Correct. This is the option, ocular massage and immediate paracentesis. So what is the diagnosis in this case? See, they are talking about an elderly patient with a history of heart disease. This history of heart disease probably is given to us to suggest a possibility of embolism. And on examination, see, the whole retina appears to be edematous and pale, except for this fovea, which is bright red. And that's why only the fovea is appearing to be bright red and the whole retina is appearing to be pale. And this is called as cherry red spot, correct? So the diagnosis here is CRAO. CRAO stands for what? Central retinal artery occlusion. So CRAO stands for central retinal artery occlusion. So out of these, see, central retinal artery occlusion, how do we treat it? The basic idea is that you have to suddenly lower the IOP, and this may create a jerk effect which will help to dislodge the thrombus. So how is this done? This is done by a vigorous ocular massage and paracentesis. What's paracentesis? Paracentesis means aspiration of some aqueous humor from the anterior chamber. So if you aspirate some aqueous humor from the anterior chamber, this also creates a jerk effect and it may help to dislodge the thrombus. right? So this is the treatment of CRAO, central retinal artery occlusion. Am I audible and visible? Am I audible and visible, and is the presentation visible to everyone? Please let me know if I am audible and visible and the presentation is clear to everyone. Okay. Okay. So let's proceed to the next question. Thank you. A 60-year-old patient with a history of hypertension presents with sudden loss of vision, and this is the clinical picture given to us. So what is the diagnosis? The options are CRAO, BRAO, CRVO, and retinal detachment. So which is the option that we should choose? CRAO, BRAO, CRVO, and retinal detachment. Correct. The answer is C, that is CRVO. CRVO is what? Central retinal vein occlusion. So see here they are talking about a patient who is hypertensive, which predisposes to venous occlusions, and there is a sudden loss of vision. And when you look at the fundus, what do you see? The fundus picture shows us that there are extensive intraretinal hemorrhages across the retina, multiple red patches. So what is this appearance called? This is called as typically the splashed tomato appearance. This is typically called as your splashed tomato appearance. So the whole retina is full of hemorrhages, and this is typically called as your splashed tomato appearance. So this is the diagnosis here is CRVO, central retinal vein occlusion. Right? And yes, it's also called as blood and thunder appearance, but the more commonly used name is splashed tomato appearance. Okay, let's go to the next question. A patient is diagnosed with moderate NPDR. What is NPDR? NPDR stands for non-proliferative diabetic retinopathy. Non-proliferative diabetic retinopathy. That is the early stage of diabetic retinopathy. A patient is diagnosed with moderate NPDR in both eyes. Now, what should be the first line of management? The options given to us are pars plana vitrectomy, intravitreal anti-VEGF, pan-retinal photocoagulation, or no ocular treatment, only glycemic control. No ocular treatment, only glycemic control. So what is this? What is the option that we should choose here? Correct. The answer is no ocular treatment, that is only glycemic control. That is because the stage at which the patient is NPDR, non-proliferative diabetic retinopathy. So non-proliferative diabetic retinopathy means that at that stage we are only have to concentrate on glycemic control or metabolic control. We have to concentrate on what? We have to concentrate on glycemic and metabolic controls. Glycemic and metabolic control. Right? Now, if they are given PDR, PDR is the stage of advanced diabetic retinopathy, that is proliferative diabetic retinopathy. So, if the patient is in a stage of PDR, then your answer would be this, that is pan-retinal photocoagulation, which is laser photocoagulation of the retina. Okay, so see, this is very, very important because this is a question that commonly can be asked and students tend to get it wrong. So please see what the question is asking. If the question says NPDR, that is non-proliferative diabetic retinopathy, that means that you have to concentrate on the metabolic and glycemic control only. No ocular treatment should be given at this stage. But if the patient is in a stage of PDR, that is proliferative diabetic retinopathy, then the treatment is laser photocoagulation, that is PRP. Pan-retinal photocoagulation. Okay, let's go to the next question. A 10-year-old boy is brought with complaint of difficulty in night vision, and on examination, this is the picture where you see a pale disc with bony corpuscles or bony spicules. What is the next investigation that we should do? The options given to us are FFA, that is fundus fluorescein angiography, USG-B scan, USG-A scan, or ERG. ERG stands for electroretinogram. So what is the investigation that will help us to confirm the diagnosis, the clinical diagnosis? Tell me, what is the option we should choose here? Let me tell you, the option that we should choose is D, that is ERG. ERG stands for electroretinogram. Electroretinogram. So first of all, what is the diagnosis here? See, the child has been brought to us with complaint of difficulty in night vision. And on examination, we have this. In this, they are saying that there's a pale disc and bony spicules. What are these bony spicules? See, these clumps of black pigments that you see in the mid-peripheral retina, these are your bony corpuscles or bony spicules. So these clumps of black pigments here. So together, what is the diagnosis here? Diagnosis is retinitis pigmentosa. Yes, it is retinitis pigmentosa. Retinitis pigmentosa is a dystrophy of the rod cells of the retina. It affects the rod cells of the retina, and that is why there is a complaint of difficulty in night vision, that is nyctalopia. Why? Because the rod cells are responsible for night vision. So therefore, if the rod cells are affected, the patient will have difficulty in night vision or nyctalopia. And how do we confirm this diagnosis? We will confirm the diagnosis by doing a test which is called as ERG or electroretinogram. So electroretinogram, it is the investigation of choice for confirming the diagnosis of retinitis pigmentosa. Okay, let's go to the next question. What is the diagnosis from this? Is it retinitis pigmentosa? Is it Best's disease? Is it Oguchi's disease or Stargardt's disease? So see, there is this kind of a blackish shiny patch at the macula. So what is this? Obviously, you know it's not retinitis pigmentosa because we have just seen the picture of RP. What is it? Is it Best's disease, Oguchi's disease or Stargardt's disease? What is this? Correct. This is Stargardt's disease. This is Stargardt's disease. Here, this black Stargardt's disease is also a retinal dystrophy. It's also a retinal dystrophy, but it affects the macula. And this appearance, this shiny blackish patch that you see at the macula, this has a name. It is called as the beaten bronze appearance of the macula. What is it called? It is called as the beaten bronze appearance of the macula, or it may be called as the beaten metal appearance of the macula also. So if you get this kind of an image, if they give it as an image-based question, or they can give it as a clinical question also, that an 8-year-old boy is brought to us with bilateral progressive loss of vision, and this is the fundus picture. So this is a picture of Stargardt's disease, and this appearance is called as the beaten metal appearance of the macula. Now I want to show you another image. See, this is an image of Best's disease. This is also a dystrophy which affects the central retina, and here also the patient will be brought to us with progressive loss of vision in childhood. But here you will see this bright yellow patch at the macula, which is called as the egg yolk appearance. So this appearance of the macula is called as the egg yolk appearance, and this brilliant yellow patch here, this is because of the deposition of lipofuscin pigment at the macula. The deposition of this lipofuscin pigment at the macula is giving rise to this brilliant yellow patch at the macula. Right? So this is Best's disease and this is Stargardt's disease. And the previous one that we saw, this is retinitis pigmentosa. So retinitis pigmentosa we identify by these black patches here, clumps of retinal pigments. Stargardt's disease by this blackish shiny patch at the macula, and Best's disease by this brilliant yellow patch at the macula. Okay, let's go to the next question. A 2-year-old child presents with leukocoria in the right eye since 2 months. On examination, there is a total retinal detachment, and ultrasonography B scan reveals a subretinal mass with calcification. What is the possible diagnosis? The options given to us are Coats disease, retinoblastoma, toxocara, or retinal tuberculoma. What is this? Correct. This is retinoblastoma, which is the most common intraocular malignancy in children. Excuse me. This is the most common intraocular malignancy in children. And the general presentation of these children is around 1.5 to 2 years. So they have given to us a 2-year-old child, right? And what is the presentation? The presentation is leukocoria, which means white pupillary reflex. So this is what these children present to us with. So look at the left eye here. You see that the pupil is white. So this is leukocoria. Leukocoria or white pupillary reflex. And why is this red? Do you get this white reflex? Because see, there is this mass which is arising from the retina and it is growing into the vitreous cavity, and this is what is giving us this white appearance. So this mass which is arising from the retina and growing into the vitreous cavity is giving this whitish appearance, that is leukocoria, and this is your retinoblastoma. This is the retinoblastoma. Now, when you do a USG-B scan for a retinoblastoma to confirm the diagnosis, you will get to see a mass with calcification. So, mass with calcification, this is one of the important features of retinoblastoma on USG. And they have given us a picture of this clinical specimen after enucleation. And you see, this is your mass. This is the retinoblastoma. Right? And if you were to do a histopath of this mass, then it will most probably it looks like this, where you have a central lumen like this, and the tumor cells are arranged around this central lumen. So the tumor cells are arranged around this central lumen, and this pattern of arrangement, it has a name. It's called as the rosette pattern, and this particular pattern, it is called as the FW rosette. That is the Flexner-Winter-Steiner rosette. FW rosette or Flexner-Winter-Steiner rosette. FW rosette or Flexner-Winter-Steiner rosette. Okay, let's go to the next question. A patient presents with bilateral retinoblastoma. In the right eye, the tumor is filling the globe, and in the left eye, there is a mass which is measuring 1 mm in diameter. Now, what is the management? Now, it says enucleation of both eyes, chemotherapy, enucleation of the right eye, and focal therapy of the left eye, or radiotherapy. So what is the answer that we should choose for this? Enucleation of both eyes, chemotherapy, enucleation of the right eye, and focal therapy of the left eye, or should we choose radiotherapy? So what should be our answer? Nobody wants to try? The answer is this, that is C, enucleation of the right eye and focal therapy of the left eye. Because see here, there is a bilateral retinoblastoma. In the right eye, the tumor is, they are talking about intraocular RB. So what do I mean by intraocular RB? Intraocular means it is still inside the eyeball and it has not spread outside the eyeball. So it is intraocular. Now, intraocular RB, in the right eye, the tumor is filling the globe, meaning it is large enough, that is, it is occupying more than 50% of the globe. Whereas in the left eye, it is less than 50% of the globe. Now, if the tumor is more than 50% of the globe and it is intraocular, if it is intraocular and it is occupying more than 50% of the globe, then you have to enucleate the eye. What is enucleation? Enucleation means removal of the eyeball with a portion of the optic nerve. Removal of the eyeball with a portion of the optic nerve. Removal of the eyeball with a portion of the optic nerve. This is called as enucleation. And what do you mean by focal therapy? Focal therapy is done when you have an intraocular retinoblastoma, but it is not occupying more than 50% of the globe. It's a small mass. So you don't want to remove the eyeball, you just want to treat the tumor, and that is called as focal therapy. So see, in this question, they are talking about a child with bilateral RB. In the right eye, the tumor is very large. Both are intraocular, but in the right eye, it's very large. So you have to remove the right eye, that is enucleate. In the left eye, it's intraocular and it is small. So that's why we have the option of saving the left eye by doing focal therapy to the left eye. So this is the answer. So C is the answer. Okay, let's go to the next. The visual complaints of a patient are shown in this picture. Now, what is the possible diagnosis? Is it a mature cataract? Is it a hypermature cataract? Is it a posterior subcapsular cataract, or is it a nuclear cataract? What is this? The visual complaints of a patient are shown to us in the picture. What is the possible diagnosis? What should we say? Is it a mature cataract? Is it hypermature? Is it correct? It is a posterior subcapsular cataract. Correct. So first of all, let us see what is this picture showing us. It is showing us some bright lights which are spreading. So what is this called when bright lights are spreading? This is called as glare. So this is called as glare, and glare is one of the main features of a posterior subcapsular. Glare is one of the main features of posterior subcapsular cataract. So the visual complaints of a patient here is glare. He is mainly complaining of the spreading of light, especially at night. So this is typically a feature of posterior subcapsular. Okay, now let's go to the next one. A 60-year-old patient suddenly notices an improvement in his near vision with his right eye. And on examination by the optometrist, the refraction in the right eye has changed from minus 1.5 diopters to minus 4 diopters. Now, what is the possible diagnosis? The options given to us are posterior subcapsular cataract, mature cataract, nuclear cataract, or Morgagnian cataract. So what is the diagnosis here, do you think? Okay, the answer to this is nuclear cataract. Now let's look at the question and try to understand what they are trying to tell us. So see, there is an elderly patient, and what has happened to this elderly patient? His refraction has changed from minus 1.5 to minus 4. So there is a myopic shift in refraction. There is a myopic shift. But see, this increase in myopia, this is not a child, this is an old patient who has a myopic shift. So when elderly people have myopic shift, this means this type of myopia, it is called as index myopia. And why do you have index myopia? Because there is a change in the refractive index of the lens. There is an increase in the refractive index of the lens due to the development of a nuclear cataract. Okay, so an elderly patient gets a myopic shift in refraction. This is called as index myopia. And why do you have this index myopia? Because there is an increase in the refractive index of the lens due to the development of a nuclear cataract. And what is the presentation of this? These patients, they present with difficulty in distance vision, but there is a sudden improvement in their near vision. So they will say that they are not able to see clearly for distance, but they are very happy with their near vision, or they will say that my near vision has actually become much better than what it was before. So this sudden improvement in near vision that they have, this is called as second sight. This is called as the second sight. So sudden improvement in near vision that we have, this is called as the second sight. Okay, so this is nuclear cataract. So see, in the previous question, we talked about glare and halos, which is the presentation of posterior subcapsular cataract. This is index myopia, which is the presentation of nuclear cataract. Okay, let's go to the next question. A patient presents with a bilateral subluxation of the lens. So let us assume this is the left eye. This is the left eye of the patient. And what is the possible diagnosis? So the options given to us are Marfan syndrome, homocystinuria, sulfite oxidase deficiency, or Weil-Marchesani syndrome. So which one will you choose? Marfan, homocystinuria, sulfite oxidase, or Weil-Marchesani? Correct. The answer is Marfan, because see here, this is the left eye of the patient, which means that this is nasal and this is temporal. So if I look, this is the margin of my lens, which says that there is a superotemporal subluxation of the lens. There is a superotemporal subluxation of the lens. And superotemporal subluxation of the lens is seen in Marfan syndrome. Now, why it's not homocystinuria? Because homocystinuria, commonly we see inferonasal. Position of the lens in homocystinuria typically is inferonasal. So, superotemporal for Marfan and inferonasal for homocystinuria. Okay. So these are the questions that I had for you today. So this is just to give you an idea about the type of questions that we can expect in the upcoming exam. So questions nowadays, they are not very, I'll not say they are exceptionally difficult, but they are like more clinical, more image based. So this is the kind of questions that we should be practicing for the exam, right? So those of you who are still not a part of our platform, do download the app. And if you want to enroll for the plus subscription, then you can use my code, that is Dr Sudha. And this is the FMG batch that is running on our platform. This started on the 11th of July and it will run from July to December. And this is going to have a complete coverage of all the 19 subjects. And it is structured so that you will be able to do well in your December exams, right? So thank you very much, everyone. You do download the app and do join the community so that you will get updates about the other free classes that we will be special classes that we'll be doing on our platform. So thank you, everyone. Hoping to see you in the other classes as well. Bye bye.